Hello people, in this video we want to look at the steps of functional endoscopic sinus surgery, right? We want to look at the steps. In the previous video we have looked at what exactly it is, functional endoscopic sinus surgery. So basically nowadays this is minimally invasive and performed and it has replaced almost many surgeries, right? You have looked at why it is happening because of greater technology, etc. Right? So this is the Zomed microdebrider, etc. So these are some tools. In this, what you will be reading about now in the steps will be sickle knife, the sickle knife, okay, and then these Balkesley forceps, okay. We also saw this endoscope. Then we saw why you would do the surgery, basically sinusitis mainly. Then epistaxis if you want to do cautery, if you want to remove a foreign body, and if you want to do septoplasty, some septal surgery. So you can also do it for removing tumors, for going and accessing even orbital abscess, cellulitis. Sorry, so many ophthalmic surgeries also they are doing, like dacryocysto-rhinostomy. If you want to fix a CSF leak, if you want to do even a pituitary surgery, if you want to decompress the nasal, optic nerve, if you want to do orbital decompression for Graves' disease, etc. Some posterior epistaxis is there, and you want to control the posterior epistaxis by clipping the sphenopalatine artery. If there is choanal atresia, you can fix it, right? So many things you can. All this we have seen in previous video. Then what else? We saw the contraindications. It needs a lot of experience and proper instrumentation. So if you don't have that, it will be a contraindication. There are some things that you cannot do with this FESS, like especially in frontal sinus, the lateral part, lateral frontal sinus disease. If there is stenosis of the internal opening of frontal sinus, so those things are inaccessible. If there is osteomyelitis, so if there's some bone problem, and then if there is some threatened intracranial or intraorbital complication, if you feel that it can go into some complication with those, then those are all contraindications, okay? Anesthesia usually general, but if it is a minor procedure and limited work has to be done, local anesthesia can be given. Position is just patient will lie supine. If you want, the head can be elevated by 15 degree, right? This is the FESS in progress. So techniques we saw anterior to posterior, that is Stramberger technique. Anterior to posterior means uncinate to sphenoid sinus. This will be anterior to posterior, Stramberger technique. And then in revision sinus surgery, they'll go from back to front, or even if there is extensive polyposis, so they are going back to front in revisional sinus surgery. That will be from the sphenoid sinus along the base of skull and medial orbital wall, okay. So you have two techniques, right? So now techniques over. Now in this video basically we want to focus on the steps of FESS. Initial steps you look at. So first of all, from the nose, if there's any cotton, okay, so cotton pledgets kept, then you can remove them, right? If they were kept, so you remove them. Then what you do is you inspect the nose with 4 millimeter 0 degree endoscope, or do complete nasal endoscopy if not already done. So you will inspect the nose basically. Can you tell this? 4 millimeter 0 degree.
0 degree.
Yeah, so some specifics there. So you're just removing the cotton, checking the nose, right? Then you will give anesthesia. Submucosally 1% lignocaine with adrenaline, that is 1:1 lakh adrenaline. So you are giving submucosally, you're injecting 1% lignocaine with adrenaline. This is standard local anesthesia, right? Under endoscopic control you are going to give. So look at this, where and all you will give, they have shown here in this image. So here 3 stars are there, but actually 2 more places they are indicating. See, this one is, this is the uncinate process, this is the middle turbinate, and this is your septum, right? So where they are giving here, the first one A, and then below that injection site B, and then here they are giving one more. Let us see these. On the lateral wall, okay, on the lateral wall near the upper end of middle turbinate. As this is the middle turbinate, near the upper end of middle turbinate, lateral, on the lateral wall, they are giving the this is the injection they are giving, the local anesthesia. Then on the lateral wall again, just below the first injection, they are giving the second one. On the lateral wall again, just above the inferior turbinate, okay. So where is the inferior turbinate here? Inferior turbinate is here. This is the middle turbinate, right? So inferior turbinate, middle turbinate, here you have the uncinate process. So 3 injections over. Where are they giving the next 2? In the middle turbinate, posterior aspect, okay. In the middle turbinate, posterior aspect they are giving. Posterior aspect of nasal septum also they are giving. Okay, so 2 more, where are they? Posterior aspect of middle turbinate, in the middle turbinate, posterior aspect, and septum, posterior aspect of nasal septum. So A, B, C, D, E, 5 injections, okay. Looks like 5 injections, guys. Next, replace the cotton, I'm thinking, how is this pronounced? Pledgets, okay, they're going to replace it, and in the opposite side, in the other nose, right, also they will do all this. If the they need to do bilateral functional endoscopic sinus surgery. If they need to do the surgery on both sides, then they'll do bilaterally, they will do this anesthesia, right? They'll give it. So now let us see in initial steps itself, little more is there. Let us see these. They will medialize the middle turbinate and identify the uncinate process and bulla ethmoidalis. Okay, let us see what this is. So what are they doing? They will medialize the middle turbinate. So they will just make it medial, is it? And then they will identify this uncinate process and bulla ethmoidalis. So here you have the middle turbinate and here you have the bulla ethmoidalis. So if you want to see this, they are medializing this middle turbinate and they are locating the uncinate process and the bulla ethmoidalis. Okay. Then after this, if this middle turbinate is large, they are doing a partial or total turbinectomy. So if the middle turbinate is large, they are doing a partial or total turbinectomy. In case of concha bullosa, lateral lamella is removed. What is this concha bullosa? Guys, in the osteomeatal complex video, we already have seen what this concha bullosa is. So let us see what this is again. Concha bullosa is the pneumatization of the middle turbinate. Okay. It is present in 30% of the population and is usually asymptomatic. So what is it doing? So if it is pneumatized, then it can have some drainage system, right? So the obstruction to the drainage system of this concha bullosa can result in symptoms. It requires endoscopic sinus surgery, removal of the medial wall of concha or the entire concha bullosa. So it is just a pneumatization of the middle turbinate. So if there is a pneumatization here, right, concha bullosa, then laterally, that lateral lamella they are removing. Okay. So middle turbinate, they can do partial, total turbinectomy if required. They can remove the lateral lamella if there's a concha bullosa. Okay. So these are all initial steps. They have made their way through. So middle turbinate, etc. They have made their way through. They have seen the bulla ethmoidalis and the uncinate process, everything they have done. Now we will go to the definitive surgical steps of this functional endoscopic sinus surgery. So in this, what and all they are doing? If it's required, uncinectomy, then enlargement of maxillary ostium. So basically, they are going to enlarge the opening of the maxillary antrum, the maxillary sinus. Then they are doing bullectomy. Bulla ethmoidalis is penetrated, okay, with this forceps. We'll come to all this. Then what are they doing? They are removing the posterior ethmoidal cells, okay. Then frontal sinusotomy if required. Then sphenoidotomy if it is required. Then finally nasal packs. So this is what they are doing, guys, right? So that's it. 7 steps they are telling. Let's look at these. So we're looking at what? Definitive surgical steps, right, of FESS. So using that image, let us try to understand. So what are they doing? Uncinectomy, uncinate process, something they are doing. Then they are enlargement of this maxillary ostium. then bullectomy, then removal of posterior ethmoidal cells. Where are those posterior ethmoidal cells? Here, posterior ethmoidal cells. All these are posterior ethmoidal cells. Okay. Then optic nerve will be at risk. When you are doing this, be careful. So what are they saying? If Onodi cell is present, then optic nerve is at risk. What is this Onodi cell? It is the Onodi cell is a posterior ethmoid cell which extends into the sphenoid bone lateral and superior to the sphenoid sinus. So if there is an Onodi cell here, so the optic nerve will be at risk. So you should be careful. Then after this, frontal sinusotomy if required only they are talking about. So where is your frontal sinus? Remember, with this frontal sinus only they have contraindications, limitations of the surgery, especially lateral part of frontal sinus, they cannot do much. And if there is stenosis of the internal opening, they can't do much. So if they're saying that in the CT scan, if it is clear and if there's no symptoms, then you can not bother about this. But if there is anything, then you can do a frontal sinusotomy. Okay guys, so we have looked at most of the steps, then we're coming almost to the end. Look at the next step here. Sphenoidotomy. This is also only if it is required they are doing this. So sphenoidotomy. So we will look at details, but this is sphenoid sinus. Sphenoidotomy if required. Then finally nasal packs. So basically the drainage, ventilation, everything they are achieving of all these sinuses. So let's look at it in detail now. So guys, just first of all, they will do uncinectomy. So with what? With the sickle knife and with a Blakeslee forceps. Okay, this is sickle knife and this is Blakeslee forceps. With that, they are doing an uncinectomy. Okay. So first of all, what are they doing? Uncinectomy. So they are doing uncinectomy. This uncinate process is incised with sickle knife. Okay, and it is removed. They are removing this uncinate process. Okay. Then they are identifying this maxillary ostium and enlarging it. How will you identify it? Maxillary ostium lies above the inferior turbinate and posterior to lower third of uncinate process. So see that here. So maxillary ostium lies above what? Above the inferior turbinate. Yes. And it is posterior to lower third of uncinate process. Okay. Then once you locate this, okay, it is enlarged anteriorly with back-biting forceps or posteriorly with a through-cut straight forceps. So some back-biting forceps they are using anteriorly and posteriorly with a through-cut straight forceps. Wow. So if you can remember these names, great. Okay. Then moving on, bullectomy. So they are going and this bulla ethmoidalis, they are penetrating with curette or Blakeslee forceps and removed. So this one also they are removing. Okay, can you say Blakeslee? Blakeslee. Blakeslee. Okay, and what you should do, avoid injury to medial orbital wall, skull base or anterior ethmoidal artery. So when you're doing this, you should be careful. Don't injure the medial orbital wall. Where is that here? So medial orbital, what are they trying to do? They are trying to, this bulla ethmoidalis, they are trying to penetrate, okay, and remove. So you should avoid injury to the medial orbital wall, to the skull base and anterior ethmoidal artery. So be careful when you are doing this bulla ethmoidalis part of it. Okay, then we will move on. So uncinectomy over maxillary. So maxillary ostium you enlarged, then bulla ethmoidalis penetrated, curette removed. Okay, then coming to ethmoidal cells, posterior ethmoidal cells removal, penetration of basal lamella, removal of posterior ethmoidal cells. Okay. So what is this basal lamella? It is dividing the bony septum between the anterior and posterior ethmoidal cells. You will go through that, remove the posterior ethmoidal cells. Then again here they are using the same curette and Blakeslee forceps. Posterior ethmoidal cells are exenterated. Okay. Then here, if there is a Onodi cell which is present, which is the posterior ethmoidal cell which extends into the sphenoid bone lateral and superior to the sphenoid sinus, if that Onodi cell is present, optic nerve will be at risk, remember. Okay. Then Now coming to frontal sinusotomy, only if it is required, if there is a frontal sinus disease, then only they are clearing this recess and they're draining this frontal sinus. If the frontal sinus is clear on CT and the patient doesn't have any frontal headaches, etc., you need not do anything, okay? But only if there is a disease, then you can clear the recess and drain the frontal sinus, okay? So where will you open? The opening of frontal sinus is frontal sinus is situated lateral to the attachment of the middle turbinate. So where is the middle turbinate? Here. So lateral to the attachment of the middle turbinate, medial to the medial orbital wall. Yeah, okay. Anterior to anterior ethmoidal artery, posterior to Agarnase cells. So see, it's medial to medial orbital wall, anterior to anterior ethmoidal artery, posterior to Agarnase cells, and it is lateral to the middle turbinate. Okay, what is this Agarnase cells? Do you remember? It is an elevation that lies just anterior to the attachment of the middle turbinate that you can see here, right? So here you have the Agarnase cell. So behind that only you will have the opening of the frontal sinus, which is very clear here. So you can see the frontal sinus opening is posterior to the Agarnase cell. So now you know where the frontal sinus opens, right? So where does the frontal sinus open, guys? So it opens lateral to the attachment of the middle turbinate. Okay, lateral to the attachment of middle turbinate, medial to the medial orbital wall, anterior to the anterior ethmoidal artery, and posterior to the Agarnase cells. Okay. So the surgery in this area is very challenging. Should be very careful. Okay. So if you are not careful, it will lead to the stenosis of the frontal sinus opening with mucocele formation and recurrent frontal sinusitis. So basically you understand that one of the contraindications, limitations of the surgery is actually the frontal sinus. Otherwise everything else, maxillary fine, sphenoid is fine, ethmoid also is fine, ethmoidal sinus is fine. So only frontal they seem to have some concerns. Then coming to this, lastly they are coming to sphenoid sinus. Okay, so lastly, after talking about maxillary sinus, after talking about ethmoid sinus, frontal sinus only if required, some things they are telling. Finally they are coming to sphenoid sinus. So sphenoidotomy you will do after you have done this ethmoid sinus and frontal sinus work, only if required, whatever you are doing. Then coming to sphenoid sinus. So sphenoid sinus, sphenoidotomy. What are they doing here? So it's done after clearance of all this. Yes, we told you. And this step also you will omit if the sinus is healthy. So guys, focus. What are we looking at now? We are looking at sphenoidotomy. Can you say sphenoidotomy? Yeah, thank you. So what will they do here? They will remove the anterior wall of the sphenoid sinus and the pus and inspissated material, whatever is there, they will remove it. Only if it is there and they suspect it, only that time they'll do all these procedures, okay? Then how to remove this anterior sinus wall of the sphenoid sinus? There are two ways. Either you enter the sphenoid sinus anterior and inferior to the ethmoid cavity, okay, which you created by the above steps. Which steps did we do? Okay, then you will enlarge the opening of sphenoid sinus with the same Blakeslee forceps or J curette. So if you have this Blakeslee forceps, looks like a lot of things you can do here, right? And how does that look? Blakeslee, see this. It's called Weil Blakeslee forceps, right? The straight and extra. Good. So let's go back and continue where we were. So we're talking about the sphenoid sinus. Sinus opening is identified after removing of the posterior inferior portion of the superior turbinate. So only here they're talking about superior turbinate. Remember, till now we spoke about inferior and middle turbinate. Now they're talking about superior turbinate near the nasal septum, about 1 centimeter above the upper border of posterior choana. So if you want, you can remember the details, guys. So that is about the sphenoidotomy. So now let's go to the last step, nasal packs. Finally, nasal packs are applied. If septal surgery has to be done, you can do that, right? So if you have done septal surgery, then only they're saying you need nasal packs, is it? Finally, the nasal packs are applied if septal surgery has also been done with FESS or to stop any bleeding from the nasal cavity. Okay. So we are done with the definitive steps of FESS. Now let us go to the post-operative care. Okay. Post-operative care. Guys, we are moving to post-operative care here. So it is very easy. Remove the nasal packs, right? At the time of discharge, that is around the next day. Antibiotics you will give intravenous, like amoxiclav, etc. And then you will give same thing orally for next 7 to 10 days. Antihistaminics if the patient is allergic to, has any, allergy, nasal allergy, etc. Analgesics for pain relief, nasal irrigation, saline irrigation is started to remove blood clots, crusts, etc. So saline irrigation you can remember. Then steroid nasal sprays for people who have allergy and who have been operated for nasal polyps, etc. Endoscopic toilet, blood clots, crusts, debris are removed by suction and forceps from the ethmoid area lateral to middle turbinate. Any adhesion, it is divided with suction. Healthy mucosa should not be disturbed. Guys, focus. Suction can be done from within the maxillary sinus with a curved cannula. So they're talking about endoscopic toilet very much in detail. So this is an endoscopic toilet. Okay. So they're going with the endoscope, looks like. Since the endoscopic clearance is a painful process, topical nasal anesthetic with decongestant is sprayed before the procedure. So after this endoscopic sinus surgery, they're having an endoscopic toilet also. So patient pays a weekly visit for inspection of the cavity for 4 weeks and thereafter is required till mucosalization of the cavity is complete. So the patient will keep visiting, right, after the surgery for about 4 weeks. Okay. Complications of the surgery, guys. FESS surgery. It is very similar to the conventional surgery, but obviously this will be minimal. So it can be prevented if you take careful if you have careful surgical technique, you can minimize. Let us look at the major and minor complications. Major will be orbital hemorrhage, loss of vision, blindness, because you saw that optic nerve issue can be there, right? So there can be orbital hemorrhage, diplopia, everything about the ophthalmic symptoms they're saying. Now let us go one more level. CSF leak, meningitis, brain abscess. Okay, then these people can go into massive hemorrhage. They may need blood transfusion. Intracranial hemorrhage, brain trauma, direct brain trauma. Okay, that got scary. Anosmia, these people can lose sense of smell, is it? Injury to internal carotid artery in sphenoid sinus. In the sphenoid sinus, so if you're touching that, then you can damage the internal carotid artery. Then nasolacrimal duct can be injured. So there can be epiphora, right? So that is the drainage of the tears will not happen properly. So the person can go into epiphora, watery eyes. And look at this one here. They have written death. Usually I've never seen death being written like this. So guys, we're done with the major complications of FESS surgery. So usually it is intraorbital, intracranial, everything to do with the brain. And then some internal carotid artery because of the sphenoid sinus. Then what else did we see? Death. They have written death. Then they may need, blood transfusion. Then nasolacrimal duct can get affected. Again, a lot of ophthalmic things they have written here, right? Now let us go to the minor ones. Minor ones you can see here. Epistaxis, emphysema, periorbital emphysema, periorbital ecchymosis. Same thing around the orbit, ecchymosis, around the orbit. What is this? Emphysema, epistaxis, post-operative infection. So you'll have rhinitis or sinusitis, adhesions. After any surgery, you can have adhesions. They said no adhesions, you should separate it by suction or something. You remember post-operative care, they said about that. Then focus, guys. Can you say stenosis?
Stenosis.
Stenosis of maxillary. Say maxillary.
Maxillary.
Frontal sinus.
Frontal sinus.
Yeah, so there can be stenosis of these two sinuses, guys. Maxillary, frontal sinus, but that is a minor thing they are telling. Okay. Then continuing, you can have exacerbation of asthma and hyposmia. That means instead of a complete loss of smell, a small minor loss of smell. And then dental pain. They can go into dental pain. Wow. So can you say dental pain?
Dental pain.
Do you know what dental pain means?
Dental pain.
Tooth pain?
Tooth pain.
Yeah, something like that. So that's a minor complication of the surgery. Okay. So let's take a complete recap, guys. So basically in this video, we wanted to look at the steps of this endoscopic sinus surgery, functional endoscopic sinus surgery, FESS. Okay. So basically this has replaced a lot of conventional surgeries like Caldwell look operation, frontal sinus operation, external ethmoidectomy, etc. So basically this is minimally invasive. It does not require skin incision or removal of the intervening bone to access the disease. So slight bones, yeah, they are removing though, right? Anyways, now ventilation and drainage of the sinuses you're establishing by preserving the mucosa. Okay, so the function of mucociliary clearance, etc., it will remain. So why has this been possible? Because of better optics, better illumination, microsurgical instruments. Now you have endoscopes, you have CT, MRI, you have microdebriders. You have bone cutting drills, so you have computer assisted image guiding. So all this has made endoscopic surgery possible, right? Then this is the micro debrider with the straight blade. Then you have some sickle knife here. Then you have the Blakeslee forceps, the straight Blakeslee, curved Blakeslee forceps, J-shaped curette. All this way they will talk about in the surgery. This is the endoscope we have seen. So basically, what are the indications of FESS surgery? Any sinusitis, bacterial, fungal, polypoidal, antrochoanal polyp, mucocele, frontoethmoidal sphenoid sinus, mucocele. Then epistaxis, you can do cautery, you can remove a foreign body, you can do septal surgeries, right? Then advanced things that you can do with nasal endoscopic technique is you can remove some tumors. Please don't forget, you can remove tumors like papillomas, angiofibromas, right? Then or you can go and do some orbital surgeries like decompression, abscess, cellulitis management, dacryocysto-rhinostomy you can do. You can repair a CSF leak. Pituitary surgeries you can do. Then you can do posterior epistaxis you can control by endoscopic clipping of the sphenopalatine artery. Choanal atresia you can treat. So these are the advanced things you can do with nasal endoscopy technique. Contraindications usually are that you don't have experience or you don't have proper instruments, or if there are some inaccessible places like the lateral frontal sinus disease or the stenosis, if there is stenosis of the internal opening of the frontal sinus. So those are some things you can't do. Osteomyelitis is a contraindication, and then if you have a threatened intracranial or an intraorbital complication, then it is a contraindication. Anesthesia, general, but if it is minor work, then they are using local anesthesia. Local anesthesia with IV sedation. So it is general or local. Then position, supine position is enough. Headrest on some ring or headrest, but some people prefer to raise the head by 15 degrees. The two techniques, guys, can you say what the techniques are? Yes, anterior to posterior, Stamberger technique, that is from the uncinate process to sphenoid sinus, anterior to posterior, the Stamberger. Then you have the Weigand technique is posterior to anterior, that is from the sphenoid sinus. You will go along the base of skull and the medial orbital wall. This you will do if there is extensive pulses and revisional sinus surgery or revising from back kind of a thing. Okay. Then those are the two techniques. Then initial steps, you will remove the cotton pledgets and you will inspect the nose with a 4 mm 0 degree endoscope. So you will do a complete examination if you have not done already. It looks like initial steps only we are continuing. So you will give submucosal 1% lignocaine with 1:1 lakh adrenaline under endoscopic control only. You will give the anesthesia. Where and all you will give, see here, lateral wall near the upper end of the middle turbinate, then just below that, and then just above the inferior turbinate. Then you will give posterior aspect of middle turbinate and then posterior aspect of nasal septum. So these are the 5 places they are talking about the lignocaine injection. Okay. Then you will replace the cotton pledgets and repeat the injections on the other side in case you want to do bilateral FESS. Okay. Then you will medialize the middle turbinate to identify the uncinate process and bulla ethmoidalis. So this middle turbinate, you will medialize it so that you can see the uncinate process and the bulla ethmoidalis. Okay. Then in case there is a concha bullosa, that is in the middle turbinate, in case there is pneumatization, then you will have to remove the lateral lamella. Okay. So all these are initial steps. Now you can see whatever you want to see. You have opened up your place. Now you will do definitive steps, surgical steps of FESS. So you will do uncinectomy. So uncinate process they are removing with this sickle knife and Blakeslee forceps. They are removing this. Then after this uncinate process gone, they are going to the maxillary ostium, identifying it and enlarging it. So how will they identify it? It lies above the inferior turbinate and posterior to the lower third of the uncinate process. That is where you will find the maxillary ostium. So once they localize it, they will enlarge it with a backbiting forceps. Anteriorly with a backbiting forceps, they can enlarge it, and posteriorly through a cut straight forceps. Okay, they will do enlarge the maxillary ostium. So maxillary sinus over. Next they will go to what? This bulla ethmoidalis. Bulla ethmoidalis also they will penetrate with curate or bellicosely forceps and they will remove. Okay, so and when you're doing this, you should be very careful not to injure the medial orbital wall or the skull base or the anterior ethmoidal artery which is sitting here. Okay, so now maxillary sinus over, right? So maxillary sinus part over, bulla ethmoidalis part over. Next they will go to posterior ethmoidal cells. Okay. So people, we are now going to enter the posterior ethmoidal cells. So the basal lamella which is dividing this anterior and posterior ethmoid cells, they are going to penetrate that and then they are going to remove the posterior ethmoidal cells. They won't, okay. So anterior ethmoidal cell itself is this bulla ethmoidalis. So that is over, So maxillary over, bulla ethmoidalis, that is anterior ethmoidal cell over. Now they are going to posterior ethmoidal cells. The basal lamella which is dividing these two, they are penetrating, okay, and then they are going to posterior ethmoidal cells and they are accentrating them. Okay guys, so then if there is a Onodi cell which is present, that is the Onodi cell is the posterior ethmoidal cell which extends into the sphenoid bone lateral and superior to the sphenoid sinus. Okay, so if there is an Onodi cell present, who is at danger guys? Optic nerve is at risk. Okay, focus. So now we are done with maxillary sinus over, bulla ethmoidalis anterior over, posterior and ethmoid over. Now we will go to frontal. Okay, so frontal, if only any work is required, then only they will do some frontal clearance of frontal disease, frontal sinusotomy only if it is required. See, if CT scan has shown that frontal sinus is clear and the patient does not have any symptoms of frontal headache, etc., you don't have to do anything. But if there is a frontal sinus disease, then you'll have to clear this frontal recess and frontal sinus you'll have to drain. Where is the opening of the frontal sinus? So basically the frontal sinus opens somewhere here. See here? Here. Okay, so that is medial to the medial orbital wall, lateral to this middle turbinate, anterior to the anterior ethmoid artery and posterior to the Agarnase cells. So where is Agarnase cell? You know, here. So Agarnase cell, posterior to it as well, you can neatly see the frontal sinus draining, right? So this is where the opening of the frontal sinus is. So this is actually a challenging thing to do, and usually frontal sinus only has all the contraindications, right? So if you disrespect the mucosa or something, it will lead to the stenosis of the frontal sinus opening with mucocele formation or recurrent frontal sinusitis can happen. Okay. Then after all this, then only lastly they are going to the posterior structure. So they are going to sphenoid sinus. So this looks like a Stamberger procedure from anterior to posterior. They are going right. Finally, they reach the sphenoid sinus. In case it needs any work, then only they are doing this sphenoidotomy. So they will remove the anterior wall. Okay, anterior wall of the sphenoid is removed. Sphenoid sinus is removed. First, an inspissated material. If it's there, they are removing it. How will you remove the anterior sinus wall? Means you will enter the sphenoid sinus anterior inferior to the ethmoid cavity. You will enlarge the opening of sphenoid sinus with this Beckesley forceps and J curate. Okay, so there is a lot of details here. You can look at that if you want. Then finally, after that, if any septal surgery is there, they will do. If septal surgery has been done, so that also you'll have to add here. If the septal surgery, they would have done that also. Finally, you will do nasal packing. If septal surgery has been done, or if there's any bleeding, they will do septal, nasal packing. There are so many types of nasal packing looks like. Okay. So then what are the post-operative care? You will remove the nasal pack at the time of discharge the next day. Antibiotics, you will give IV, amoxiclav, and then same thing or cephalosporin or quinolones. And you will continue them by oral route for around 10 days. Antihistaminics, you will give only if the patient has some allergy history. Steroid nasal sprays again if there's allergy history. Analgesics for pain relief. A nasal irrigation like saline irrigator, right, to remove blood clots, crusts and secretions. Then endoscopic toilet, remember after this endoscopic sinus surgery, they will do endoscopic toilet to remove blood clots, crusts, debris, etc. from suction. By suction they will remove. And if there's any adhesion, they will divide it with suction. Healthy mucosa you should not disturb. And remember, you can do suction from the maxillary sinus with a curved cannula. If you have curved cannula, maxillary sinus suction, then this is a very painful process. Again, they'll have to give topical nasal anesthetic, okay, with a decongestant. So before this procedure, so this also endoscopic toilet also they have to do under anesthesia only. Okay. Then you will pay visit for around 4 weeks till the mucosalization of the cavity is complete. So what are the complications you saw? Mainly orbital complications and intra cranial complications, orbital hemorrhage, loss of vision, blindness, diplopia. Then you can have, we saw something else here, right? Okay, and then here nasolacrimal duct is affected, so there can be epiphora. So these are all orbital. Then there can be hemorrhage, so the person may need blood transfusion. Look at what and all in the brain. You can have CSF leak, meningitis, brain abscess, intracranial hemorrhage, direct brain trauma. This person can lose sense of smell, anosmia. Internal carotid artery can get injured in the sphenoid sinus, right? Even death can occur. Wow. So coming to the minor complications, you can have epistaxis, periorbital ecchymosis, periorbital emphysema, right? Again, this is all ophthalmic, you can say. Then epistaxis, rhinitis, sinusitis, standard things you will write. After any surgery, there can be adhesion. They told you have to remove it, divide it with suction, they said, right? Then there can be this maxillary sinus and frontal sinus openings. They can get stenosed, okay? Exacerbation of asthma, hyposmia, so not full but some loss of smell, sense of smell, dental pain. Dental pain can be there, okay? So these are the complications of FESS surgery. So in this video, we have looked at the steps of endoscopic sinus surgery. Bye bye.